Welcome to the show, Healthcare from the Hill. In this show, we discuss medical topics and issues. We interview individuals from the patient all the way to the professional physician. I'm your host, Dr. Amit Lahav. Today, we're going to dedicate the show to orthopedics. And we're going to discuss two topics, one regarding the hand and one regarding the knee. We're going to begin with speaking with Dr. Ted Weisman, orthopedic surgeon, specialty in hand and wrist surgery. And we'll talk about hand contractures, which is what's called Dupuytren's contractures. You may have seen patients or individuals that essentially have their hands stuck in this position. What is it? What do we do about it? How do you get it? How do you treat it? We're going to speak about the forefront and new techniques of treating this type of Dupuytren's hand contractures. We'll then switch over to sports injuries, ACL tears or anterior cruciate ligament. It's fall season 2012. Football's right around the corner. We hear a lot about ACL injuries and knee injuries. We'll then switch over and speak with Dr. Schachter, orthopedic surgeon with a specialty in sports medicine and arthroscopy. We'll talk about ACL injuries. What is it? How do you treat it? Who gets it? There's a lot of controversy out there. How do you reconstruct this ligament once it tears? Two topics, two specialties in orthopedics. Stay tuned. We'll be right back about Dupuytren's hand contractures and ACL injuries. Welcome back to Healthcare from the Hill. I'm Dr. Amit Lahav. In today's show, we're going to start about the orthopedic topic, hand contractures, specifically Dupuytren's hand contractures. You may have shaken hands with individuals where the fingers are sort of stuck in this position. They can't really open their hand all the way. And it's not that they're not doing it, they're unable to do it. That's a contracture that develops in the palm of your hand. I'd like to go just do a general discussion about Dupuytren's hand contractures, just to give a little bit of a background. If we can go to the slides, please. So Dupuytren's contractures of the hand. Dupuytren's contracture is a fixed flexion contracture of the hand where the fingers bend towards the palm and cannot be fully extended or straightened. It's partly inherited proliferative connective tissue disorder, which means it's a soft tissue disorder. It's not a bony problem. And it was first described way back in 1831. The ring finger and the little fingers are the fingers that are mostly commonly affected with Dupuytren contractures. And this generally progresses slowly. It doesn't occur overnight. It takes quite some time to occur. And we'll discuss with Dr. Weisman really the longevity in the way this does occur. And it affects really the palmar fascia, or the palmar part of your hand, which thickens, shortens, and then contracts. The incidence increases after the age of 40, and men are more commonly affected, although as you get older, maybe about 70 or 80-year-olds, between men and women, it doesn't differ that much. There are certain risks for Dupuytren's contractures. Some are inherited, depending on what your nationality is or where your ancestry is from. Again, individuals over 40, men are more commonly affected, and some are thought to be related to possible trauma or diabetes, alcohol and epilepsy, and so forth. So if you look at this picture here, both on the upper left and a schematic for the right, you can see the contracture of the finger, which essentially it's stuck in that position. The individual cannot straighten that finger out. Here you can see on the upper left, the contracture of the small finger. On the upper right is where the finger extended. Now, in order to get from the left to the right, there are surgeries that are performed. Unfortunately, this is not coming specifically in color, but on the bottom two, you can see on the left lower side where you actually have to open up the entire finger there, perform the dissection, take out the thickened cords that are there, and then try to close it. Now, once you open that finger out and extend it, sometimes it's difficult to close the skin, as you can see in the lower right corner, where the wound is still partly open. Here again, showing in the bottom left side, as you dissect the cords, essentially you have to dissect the entire finger and free it up. And then when you have to close it, that could be a difficult maneuver. On the upper right side, it just shows a different type of incisions that are generally done, which are zigzag type of incisions. And we'll speak with Dr. Weisman regarding why that is done. Here you can see a before and after on the left side of the screen. Before, the finger is contracted. Afterwards, what happens is the finger can be extended once again, which is important. It gives more function for the finger. When we return back to Dr. Weisman here, Dr. Weisman, thank you very much for being with us today.
Good morning. Thank you for having me. Appreciate it, Dr. Lahav.
And I know your specialty essentially is hand and wrist.
Correct.
And because you're a hand guy, you shake a lot of hands.
Sure.
You may see this come up in your office just by meeting patients even.
Exactly. We see this very frequently, and you gave a great overview of what Dupuytren's disease is, even the history of it with Baron Guillaume Dupuytren, who was a Frenchman who first described it. One thing I do want to say that's very important, because some people come into my office and they see that sometimes it's just a bump on the hand or a small cord, which is Dupuytren's disease, but they are very worried that it is a tumor or some type of cancer. And I'm happy to relate to them that this is a benign condition. It's localized to the palm of the hand. It doesn't spread anywhere, and although it can get thicker and make the hand, make the digits flex more and make activities and function more difficult, it is not anything wrong or anything bad for their health. So that's the good thing about this disease, that it is not it's not a tumor and it's not a threat to someone's health at all. And as you also mentioned, the pictures of surgery, I kept them out. I'm glad you put them in. I was worried that perhaps the audience might be a little squeamish about seeing those pictures. But again, you presented the fact that to remove the fascia, and that's the way it's been done for decades, and I'll talk about the new technique we do now, but to remove that fascia, we have to make those incisions. And again, you mentioned those zigzag incisions help to take tension off of the skin when we close the skin, although that's one of the problems with surgery. As you said, sometimes we have to take skin grafts because we can't close the skin. There's one procedure called the McCash procedure where the surgeon just leaves the person's skin open and let the skin heal in, which does happen, but it takes many weeks. So there's different ways to do the surgery. But the problem with surgery is that it's a very difficult surgery, particularly because as the Dupuytren's cord moves and you dissect and move into the finger itself, from the palm into the finger, the nerve, which is looks like a little piece of spaghetti, if you will, gets wrapped around this cord. Of course, it happens so slowly, the person doesn't have any problems with sensation or feeling. The problem is, though, to dissect it surgically, the surgeon has to be careful that you keep the nerve where it belongs, because it's not a good thing to have a straight hand, a straight finger, and the patient says, well, I can't feel the tips of my fingers. So that's some of the downsides and the difficulties with doing surgery.
So there's a lot of essentially morbidity that's associated with surgery because it's a tougher surgery. If the skin stays open, that can be debilitating for quite some time. And there's obviously some risks with the nerve, with other structures. The tendon is close by as well. And especially if the more severe the deformity is between your fingers like this and between your fingers like this, it does increase the risk by performing the surgery.
It becomes exactly right. Said another way, the more flexed the finger is when we have to do surgery, the much harder it is for the surgeon, because just the positioning of the hand while we're releasing that tissue. And that is why this new technique, there's actually two techniques. One is called a needle aponeurotomy, where we use a needle to cut it, and we do this under local in the office. But the other way, and the way that the way I do it, the way the professor who first discovered this and brought it to the forefront was someone who trained me 2 decades ago, Dr. Larry Hurst, at Stony Brook, Long Island. And I'm following in his footsteps because I've seen the good results. If I could show the first, Dr. Lahav showed a lot of good pictures, but I'll show quickly the first picture, if we could have that, of what Dupuytren's disease is. Do we have that picture?
You looking for your slideshow?
For my slideshow, yes, yes.
All right, and just to say, actually, Dr. Hurst from Long Island, so this new technique, which we'll reserve a little bit to speak about as well, but really this new technique has come from the Northeast. I mean, literally across the Sound in Long Island, it was worked on, it was researched,
yes.
It came to fruition, yes. And now it's actually used across the United States.
Throughout the world, actually. And that's the amazing thing about this. In Japan, wherever, throughout the world, this technique is used with great success. And there were 2 main studies, one in the U.S. and another one in, now I don't remember, I think it was Australia, New Zealand. I believe it was New Zealand where the second study on patients was done. And
if I remember correctly, actually, in that study, the United States results were actually better than the Australian results.
I believe you're correct. They also had a larger pool in the United States. And I think you're exactly right about that, that the results were really good. I think because they treated people who didn't wait so long where the contracture was so bad, but yet it was debilitating. And as you said, people couldn't shake their hand or put their hand on a tabletop, for example.
And just, I know we're going to get more into it, but this new technique, so instead of surgery, this new technique essentially is an injection, which can be done in the office, so the patient does not have to go to the operating room. There's no open incisions on the hand. They're able to use it fairly quickly. And that's a whole new way of really treating this.
It's a terrific way of treating this. As I said, all the surgery, there's a lot of risk to it, and there's a lot of what we call morbidity, which means after the surgery, there's a lot of downtime. So this injection is a small aliquot. It's about a 1 cc injection of something called Xiaflex, X-I-A-F-L-E-X. And it's basically a collagenase. And we use the word, the suffix ASE or ACE. Collagenase means it breaks down the collagen. And this tissue that is getting tight is collagen. So essentially, it's purified collagenase, or an enzyme, that's actually made from the fermentation of the Clostridium bacteria. It's not an infection anymore. It's just manufactured now by this purified, just like a lot of vaccines are. And we inject this collagenase, or Xiaflex, to the patient. Sometimes I give a local, and I have a video to show that. You wait 24 hours, and they come back to the office 24 hours later, and the cord is now worn enough. It's like a rope that's frayed, and then it can be popped open, the finger popped open, and as you said a moment ago, no surgery, no OR.
And this collagenase, this Xiaflex injection, I think it's a combination of more than one collagenase, isn't it?
That's a very good point. If you want to get the specifics, Dr. Lahav's done his homework. There's actually 2 different types of collagenase, and they work together. They work synergistically. And so by having the 2 together, and obviously a lot of research, 2 or 3 decades of research went into this, starting out with Dr. Hurst and his assistant, Dr. Badalamenti. And through that research, they found that there are 2 types of collagenase that work together, or synergistically, yes.
And just to kind of go back to the beginning again, if a patient does come to your office and sees, and they're worried about tumor or cancer or something like that that's occurring, is this a clinical diagnosis, or do you need to do x-rays, MRIs, different blood tests? And what is really your workup for this?
Well, it's a simple workup, because there are no MRIs, there are no CAT scans or x-rays that are necessary, there are no blood tests that will show it. It's a very obvious finding to a doctor who does hand surgery work. So, like yourself? Like myself. So it's easy to tell them. Some people say, I don't care if my finger's bent, as long as I know it's not cancer, and have a nice day. So yes, it's a very easy workup in that sense. You can see it a mile away. And if we could get the picture, you did show some, but I have some other ones.
Why don't we go over to your presentation now?
Okay, if we can show that picture now. This is someone with Dupuytren's disease, and they have a nodule. Sometimes all they have is a nodule. And with the nodule, again, they think it's a tumor, and I can tell them it's not a problem, and don't worry about it. And with the nodule, it draws up the skin, and then the skin can get little creases or pits. So with a nodule next door, it's like the covers on the bed. If you crumple up the covers, you might have a little indentation nearby. If we can show the next picture, and this again shows a cord. It's a thickening right under the skin, and you see it's as though it's a rope, and it's pulling down on that ring finger. So although you can bend it all the way, you cannot straighten it out. And you can imagine, if you see the next picture, how this can get in the way. This is called it's a schematic, obviously. But it tells you that, for example, the person cannot rest their hand flat on the table because they cannot straighten the fingers or open them up. And the final picture I have here is just showing again, a schematic of where this fascia, where this tissue right under the skin is. And it's only on basically on the palm of the hand and the sole of the feet. But most of the problems we see are on the palm of the hand. And that's roughly a schematic of where it is.
And you mentioned also the sole of the feet. So patients who can get it also in their hands can potentially get it in their feet?
That's correct. In the feet, it's not called Dupuytren's disease. It's called Lederhosen disease. But essentially, it's the
same pathology.
Same pathology. If you'd like, I can show a video of a patient who will get the injection. If we have that video, I can show that now, because I find that that might be helpful to understand this, about how I do this. But essentially, as you asked me, what is it about? It's no OR. The patient comes in. I often give them local anesthetic just ahead of where I'm, it's called proximal to, or just ahead of where I'm going to give the Xiaflex injection. So the finger's nice and numb, and I come in and I give this injection of Xiaflex. So that's really how it works.
Well, why don't we go to this video?
So here's the video now, and here's a person who's actually had prior surgery, and yes, the disease can come back, and that's why this was a difficult recalcitrant case. So you see how I've actually he's had prior surgery on the small finger. I've been able to open up the knuckle joint there. That's me, obviously, touching the areas of the hand and showing where I'm going to give the injections to these fingers. Now, you see his index finger is perfectly straight, as is his thumb. Usually it affects, as you mentioned before in that good introduction, the ring and small fingers, and sometimes even the middle fingers. Those are the common sides, that side of the hand. And you see that he just cannot open up those fingers. They're stuck, as I was demonstrating there. So in this video, what I didn't show you, again, for the squeamish type, I do give the injection right to those cords, and that then we send them home, we wrap them in a small bandage. I tell them to take Tylenol or some type of anti-inflammatory medication, keep the hand elevated, and come in the next day. Sometimes they get bruising and some swelling, but certainly less so than if they had surgery. Now, the next day they come in, I again give local anesthetic so that it doesn't hurt to open up the finger, but again, it's in an office setting. And it's rather quick. I can show you, if you can show the last video, it's pretty quick, where we give the local and then you snap it open, and now the finger is straight, as you can see right there. And basically that's it. And again, there are some problems. You could get a skin tear, but that's treated with local soap, soap and water and cleansing, and that skin tear will heal. Why do we get the skin tear? Well, as you mentioned, with surgery to straighten out the finger, you can have a big gap in the skin. Here we straighten out the finger and we can get a small gap, and I mean a small gap in the skin that heals in less than a week, usually in a few days. So that's the downside of doing it. Which is a small downside compared to the surgical treatment. Then we see the patient another week later and we make sure they're doing fine. We can only give one injection per area of a cord according to the FDA, so 30 days later I can give another injection to somebody.
Do you generally do one finger at a time, or do you do both fingers?
Again, yeah, I follow the rules of the FDA, which says only one finger every 30 days, basically every calendar 30 days, and that's what we do. So sometimes this is a project. If a patient, like I showed you in that video, has more than one finger, they know that this may take a few months, but it's not stopping their lifestyle. They just come in like they were coming in for an office visit and a minor procedure, and they go home and do what they have to do. With one finger improved, they come in a month later and we do the next finger.
Do you start generally with the worst finger and working onward, or do you start sort of with the little finger and working towards the ring finger?
I usually, I can go with the worst finger. I tend to work, as you ask, from the small finger over, and we do work from the palm to the finger. So there's two joints that can be tight or flexed. The knuckle joint and then this joint called the PIP joint, and this is called the MP, or the knuckle joint. So we work on the knuckle joint first and then get to the other one. It's just a better way to work, and it's better if they do need rehab therapy after the injection to help them get more of their motion back. It's better to start from the knuckle joint and work out.
And it's a little more risky also when you work into the finger, because the nerves are sort of closer than when you're more in the palm side.
That's correct. There's a different technique, slightly, when I say different technique of where the needle goes for the finger. And I think the big fear, the big concern is that tendons, the ropes that you need that move the fingers open and close, in particular the ones we're talking about, the ones that bend the finger on the flexion side, is that if you put the needle too deep, the collagenase can tear them. That should never happen. I'll use the word never, because if the injection is done right and not put too deep and done by somebody who is intimately involved with this anatomy, that complication should not happen. And in those studies that we talked about, it was rare. It was way less than 1%. And I mean, it can be fixed and repaired, but I like to use the word, even though I say never, I never think that should happen. If you do it right, that it's a risk, but it's almost a minimal risk.
So it's really not something that's done by generalists. It's done more by someone who specializes in hand, knows the hand well, performs surgery about the hand, is more familiar, obviously, with the anatomy than just taking a needle and sticking in and injecting Xiaflex.
100% correct. It really should be done by a doctor who does surgery on the hand. For the reason is, number one, as you mentioned, who knows the anatomy. But second of all, if there is a complication that requires surgery, it should be done by the surgeon, by the person who did the injection. So in other words, I'm able to take care of any complications related to that problem. But yes, you have to know the anatomy. It's like anything else. You have to know what you're doing before you do it, and then it's a very successful thing. And that's why it's really taken over for me rather than doing surgery. And even people who've had surgery before, who've been sent to my office, I say, we can do this with this medication called Xiaflex. And you know, I'm very pleased with the results. And that's why I'm also glad you had me here to talk about it.
Well, why don't we stay tuned. We'll take a minute break and we'll be right back. We'll continue talking about orthopedics. Welcome back to Healthcare from the Hill. I'm Dr. Lahav. With me here we have Dr. Weisman, who specializes in hand and wrist surgery, and we're talking about Dupuytren's hand contractures. Those contractures of the hand where it usually affects your small finger and your ring finger, and it essentially gets stuck in a bent position. Just to recap essentially about this newer technique, or Xiaflex injection technique. So the patient comes into the office. For those of them who are maybe a little squeamish about needles, we'll kind of clarify it now. They get Novocaine, so it does numb the area so they feel more comfortable. Dan, do you go in with a kind of small needle, or do you go in with a needle?
Well, that's good because we want to know, we don't want to scare anyone away from having a treatment that can be beneficial, helpful, and help their function. All the needles are small. Let's put it that way. Certainly the needle we use to inject the Novocaine or the lidocaine is a very small needle. And in fact, what I do is I prep the skin ahead of time using either an ethyl chloride freezing spray, or I use an ice cube, which for a short period of time, put on the skin, numbs the skin so that they don't even feel the small needle that we give the lidocaine or the Novocaine with. And then we don't rush this. We wait until the Novocaine takes effect. And then when I use the needle for the Xiaflex, it's also a small needle. Because understand, that picture I showed you of the cord is not that big. So you have to be able to have a needle small enough that gets right in the middle of that cord. And to do that...
So you inject it into the cord?
Into the cord. Not deep, as I mentioned to you, because too deep you could have a problem. But it goes directly into the cord. And what I also do, since we're talking about the technique of injection, many doctors do this, is I inject some of the material, the Xiaflex, and then I just move the needle slightly over and inject another part of that cord. Think about it. If this Xiaflex, if this collagenase acts to fray the cord, think of it as a rope that we give this medication, and over 24 hours the rope frays and gets weakened so that when a patient comes in, I can snap the finger open. And I will tell you also what happens in some cases, and it actually happened the first case that I ever did with Xiaflex, is that the person came in the next day, shook my hand, which I felt was unusual, because not to shake my hand, but that he could shake my hand and his fingers were straight already. But he comes in, he puts his hand out completely in extension and says, okay, what do we have to do now? Or either that, or he said, all right, I'm ready. What do we have to do now? And I said, we don't have to do anything, because it worked without the manipulation part of the procedure. And that happens too, that someone goes to a cupboard and grabs something and all of a sudden it pops open, even though they're wearing the bandage after the injection.
So this injection is almost like pouring acid over a rope. It kind of breaks through it, and the rope may break, or you may have to kind of stretch it out to break it.
Exactly. But don't worry, it's not acid, but it's a good way, it's a good metaphor to think about it. And I'll say something else. Sometimes when I do the manipulation, and again, that's done under the local anesthetic the next day, the patient gets, let's say, 80% improved from bending down to pretty much full extension, but not full extension. Interestingly, they either can do some home exercises for it to keep every day trying to stretch it, and sometimes when they do just general daily activities, they may do something where they push open a door, maybe someone's doing a push-up, and all of a sudden it snaps further, which means it may take, yes, it's 24 hours, but they may still notice good results if they don't have a completely good result in a week or 10 days, 2 weeks later, which is a great thing too.
And you shouldn't worry if you get some black and blue in the area or some swelling, obviously.
Right. Well, again, it is a collagenase. It is an enzyme that breaks down that tissue. And while it's breaking down that tissue, can irritate the tissues and cause some swelling or bruising. I tell people to expect it, because to expect some swelling and bruising, because it almost happens all the time, but it's not very painful, and they know to expect it, and then they don't worry when they see the bruising. Certainly less so than if you had cut it open and did surgery anyway, so they're happy to know that.
And just to touch very briefly on that other treatment method that you mentioned before with the needle, we essentially stick a needle and try to kind of tear that cord?
Right. Another way to do it is something called needle aponeurotomy, which has gained some success, and in some surgeons' hands does a very good job. Instead of giving the collagenase or the Xiaflex injection, and instead of doing the surgery, they numb the area and they take a little bit bigger needle than we talked about that I use, because you need a little bit bigger needle, and they literally put the needle in and they scrape that tissue away. The ones who know the technique, like I know this technique, say it works great and there's very little side effects or complications. There are nerves, though, that are, as I mentioned before, that are right around that cord, and my concern is it's a blind cut. And when you scrape away with that needle, I worry about the nerve, whereas the collagenase injection even if it hits the nerve doesn't have collagenase, so you're not hurting the nerve if the fluid, if the collagenase, if the Xiaflex hits the nerve. Whereas if you have the needle, my concern, again, because it's a blind cut, what other tissues are you affecting? That's my problem.
Well, Dr. Weisman, thank you very much for your time and expertise. Again, hand surgeon, Dr. Ted Weisman from Milford, Connecticut, with Xiaflex type of procedure or technique for these contractures of the hand. So you too can end up giving high fives when you get those fingers straight, and it works. Dr. Weisman, thank you very much again, and stay tuned. We're going to shift over to sports injuries, ACLs, anterior cruciate ligament. We'll talk to Dr. Aaron Schachter, specializing in sports medicine and arthroscopy. I'm Dr. Lahav. We'll be right back to the show. Welcome back to Healthcare from the Hill. I'm Dr. Amit Lahav, and we're going to switch over to talk about sports injuries, specifically the ACL, or anterior cruciate ligament. We see this injury quite often as women get more involved in sports, especially in the past decade or so, where women are more involved in sports. We see it occur even more in women, but men has been having these injuries for quite some time. Football, lacrosse, running, jumping, pivoting type of maneuvers. The ACL is an important ligament within your knee. It actually gives you quite significant amount of stability to the knee. And I just want to go briefly over the ACL. If we can go to the presentation, please. So the ACL, or the anterior cruciate ligament, there are essentially 4 ligaments in your knee, to put it sort of very easily. The cruciate ligaments, which are the inside ligaments, and they're the anterior cruciate ligament and the posterior cruciate ligament, and then the collateral ligaments, which are outside your knee, which are the medial collateral ligament and lateral collateral ligament. We'll concentrate on the ACL, or anterior cruciate ligament, which is one of the main 4 ligaments within the knee. It is critical to knee stability, and people who injure this ligament feel like the knee gives out. Essentially, they have this instability. They can't trust their knee. Every time they pivot on it, they feel that they go one way and their knee goes the other way. Therefore, those who do sustain an injury to the ACL opt to have surgical treatment, and we'll speak with Dr. Schachter regarding, does everybody need treatment or not? Is there an age difference as well? So the ACL tear is most often a sports-related injury, but about 80% are sports-related ACL non-contact injuries, which mean you actually didn't hit another person. It's a non-contact type of injury to this ligament. When it does occur, the knee usually feels like it's unstable, it shifts one way or another. You can't do any cutting type of activities like running. You can't pivot on it. When it generally occurs, you get swelling within the knee. You have difficulty walking. Most individuals who play sports and have this injury have difficulty walking off the field. And females, more recently, are seen to have this more propensity for this injury to this ligament. And again, we'll speak with Dr. Schachter maybe why that is. So going back to the knee, on the left side of the screen, it's sort of a side or oblique view of the knee. On the right side is sort of a head-on view of the knee. The bone on top is called the femur or thigh bone. The bone on the bottom is called the shin bone or tibia. And the patella is the kneecap in the front. On the inner part of the knee, it's called the MCL, the medial collateral ligament. And on the outside part of the knee is called the lateral collateral ligament or LCL. Those give you sort of side-to-side stability. Within the knee, it's the anterior cruciate ligament, which is the ACL, and the posterior cruciate ligament, which is the PCL. And they actually provide you stability front to back. And again, we'll talk about front to back, which one gives what. So what happens to the ACL? Usually it's a pivoting type or torquing type of activity, which stresses this ligament, and then this ligament tears. Once it tears, it gives you instability of the knee. And if you look on the right side of the screen, these are arthroscopic pictures when we essentially put a scope into the knee and take a look. On the upper right side is a frayed ligament. It's sort of ruptured, almost like a rope type that ruptured. On the bottom two sides on the right side, the ligament actually came off the femur or the thigh bone. It's almost like a hole that we look right towards the back of the knee, which should not be there. The ligament should be attached to the bone or the lateral femoral condyle. How do we diagnose it? Besides clinical diagnosis, which we will go over, you can also get an MRI. On the left side is a schematic just showing the femur thigh bone on top, tibia or shin bone on the bottom. The ACL is marked there. On the right side is an MRI, which looks at the ACL. There's a line going through it just to indicate where the ACL should be. And generally in this sequence of MRI, the ligament should be black. It should be continuous. But here it's not. You actually see some white or gray in that area, and that indicates that there is a tear. Well, what do we do when it's torn and you have instability? This ligament doesn't heal. And if it doesn't heal, you'll have persistent instability, and it can actually injure other structures, which we will discuss. How do you reconstruct it? There are multiple ways, and there's still a lot of controversy in the sports literature regarding what is the best way to fix this. The two biggest ways that it's approached is using your own tissue. One is the patella tendon, which is a tendon in the front part of your knee going from your kneecap to your shin bone. And the other is actually using your hamstring tendons. There are pros and cons about both of these type of reconstruction, which we will go into specifically with Dr. Schachter. Here, just showing a bone tendon bone reconstruction. This is where you use your own patella ligament. On the left side, it's showing just the x-rays, where the white is actually screws, which are used to hold the bone plug into the femur and the bone plug into the tibia. And you actually can't see the tendon here. On the right side, the upper side, it actually shows an arthroscopic picture or a scope picture of the ACL once it's reconstructed and it's back where it should be within your knee. So we'll introduce Dr. Aaron Schachter. Thank you very much for coming on the show, Dr. Schachter.
Thanks for having me, Amit, as always.
And because we obviously work together and we're partners, I have a history in sports medicine, and you are sports medicine. I know you also work with professional teams, New York Jets and Long Island Islanders, so you've seen these injuries from the professionals all the way to now. You even cover local high schools, and you've done this before, and you have to see a lot of these injuries come across. And a lot of these cases we do together, and we always kind of speak about what's the best way to do it, where do you put the tunnels, who should have it, who shouldn't. Let's just kind of go back and just say somebody comes into you. What's generally the population that you see this type of tear?
So the population is very broad. You're going to have the athletic population. It can happen from just a trip and fall. I've seen it. But for the most part, it's going to be from a pivoting sport, and it's going to be seasonally related. So typically in the fall, you're looking at soccer and football. As you spoke before, women are at a higher risk than men. If you look at sports that women play and men play, so if you compare soccer, basketball, and lacrosse, women are probably at 5 times increased risk for an ACL injury. as the seasons go along, winter, you're looking at basketball and skiing. But I think it's important to remember that a large part of our population are not, they're not necessarily high school competitive athletes, or certainly not everybody's a professional athlete, but most people are kind of recreational athletes. So these injuries can kind of occur, 12 months a year, because people are always involved in things.
And for the female viewers out there, why are females more at risk? It's got to be the anatomy is different.
Right. So it does have something to do with the anatomy, and it has something to do with the relative angle of the knee as it compares to the pelvis and to the foot. There's a large proponent of landing mechanics, how women land from a jumped position versus how men tend to land from a jumped position. And this is one way we've actually identified where if you can identify an at-risk athlete, particularly a female at-risk athlete, there is some validity to having a preseason kind of neuromuscular training program where they go through a series of exercises, and in these at-risk athletes it could potentially decrease the risk of incurring an ACL injury.
And once this occurs, let's say in the younger population, does everybody need this reconstructed?
Right. So everybody doesn't need it reconstructed. However, people that want to return to pivoting sports should have it reconstructed. A reason to not have it reconstructed is to prevent arthritis. I think that's probably a pretty commonly
accepted type of
misused reason, and we used to do it that way. When I had mine done 20 years ago, they told me it was so I wouldn't get arthritis. I think we know that the knees, at least the ones that the way we used to do it, they still get arthritis down the road. The reason to have it is to A, prevent injury to secondary structures, as you spoke, specifically the meniscus and the articular cartilage inside the knee, and B, to give a stable knee for return to pivoting sport. So I suppose if somebody was willing to give all that up, they wouldn't have to have it reconstructed. The problem with having somebody young is that they have a very long time in their lifetime. So, I always tell people, running after your kids is a pivoting sport, so, as you know.
Of course. And so if you have this injury occur and you don't take care of it, and you kind of try to cope with it, you mentioned the meniscus. The meniscus are essentially almost like the shock absorbers within your knee. There's two menisci in your knee, one on the inside part of your knee, one on the outside part of your knee. And there is actually a difference if you have an acute ACL injury, which means it occurred fairly recently. The lateral meniscus is the one that can actually get injured more.
Correct. A slight preponderance of lateral meniscal injuries.
But if you had an unstable knee or ACL tear for quite some time, it's actually the medial meniscus which gets injured more.
Correct. And those are some of the concerning injuries because having a problem with your medial meniscus has been identified as something that may decrease the likelihood that you have a kind of good to excellent result. So once somebody goes on and then maybe they tear their medial meniscus in a subacute or chronic fashion, they've the ship has sailed. You can't have that back. So that's why we recommend getting to them. Certainly not emergently. You have to have good motion to have an ACL reconstruction because a stiff knee before surgery will be a stiff knee after surgery. But we don't want too many months to go by because there's a very close linear relationship. So as time goes on, the likelihood you injure one of these other things goes up accordingly.
And once you injure it, that's it.
That's it.
You're done.
You can't undo that. I tell people, we can give you a stable knee, but if you have an irreparable meniscus tear, certainly if you have a cartilage injury, we can't. That's a little more difficult to deal with. Although all the importance is placed on the ACL, but some of these other things actually are maybe stronger predictors of outcome.
And if that occurs, then you're much more likely to get arthritic changes later on, because as your knee is unstable and it keeps on shifting inside, you stress the articular cartilage, or the cartilage that covers your bone.
Right. The cat's out of the bag.
And then it's done. And that's somewhere down the line, you're probably looking at having a knee replacement because of this.
It certainly increased the likelihood of that.
Well, why don't we stay tuned, and we'll be right back, because I'd like to actually go into the operative treatment for ACL injuries, because again, there's a lot of controversy out there of how do you do it, where do you put these tunnels, how do you reconstruct it, what graft do you use. We'll speak with Dr. Schachter about ACL injuries. Stay tuned.
return to sports and stuff like that.
Welcome back to Healthcare from the Hill. I'm Dr. Lahav, and with me today I have Dr. Aaron Schachter, specializes in sports medicine and arthroscopy, orthopedic surgeon. We'll go into ACL injuries and the reconstruction. So once you determine that that's what you have to do, you got to get that stable knee back. You need surgery. Well, let's talk about some of the grafts. What graft do you use? How do you reconstruct it?
So I think it's an important point. We don't repair ACLs. It didn't work. My dad had one in the late 70s, early 80s. I can tell you it didn't work because that ligament inside the knee, it doesn't heal. It's not a good healing environment. So what we have to do is reconstruct it. And the way we reconstruct it is we use tissue from somewhere, which is called a graft, to reconstruct the ligament. There are a couple important parts of the graft. There's the part which is inside the joint itself, which is actually going to be the new ACL, the new ligament tissue. And then there are the parts of the graft which are inside the bone. Although they don't necessarily work like the ligament, that's how the ligament gets fixed to you. So we don't just kind of stick it on the end of the bone. It has to be within the bone in these tunnels and sockets to create a strong anchor point for the ligament to heal.
Of course. And then let's talk about the different grafts. And there's really sort of, well, there's 4 grafts. One of them was synthetic graft, which always failed.
Right.
And that's not a viable choice. But
Right.
let's say, what about the other 3 options?
Sure. So we have 2 broad categories, your tissue or somebody else's tissue. So obviously the somebody else's tissue is going to be cadaveric graft. And there are probably 3 places that we can take your tissue from. So as you showed before, you can take the central third of the patellar ligament with a piece of bone on either side. That's probably, I don't want to say the gold standard, but certainly it's we have the most experience with that time-wise, and I'm sure certainly numbers-wise. All graft has its drawbacks. So if there was one perfect graft, we would be sitting here having this conversation about the one way it's done. Different surgeons like to do it different ways for their reasons, but I think we should always understand that that is a surgeon preference. It's not a strong, overwhelming medical evidence, although everybody has their reasons. Another option for autologous or your tissue would be 2 of your medial hamstring tendons, the gracilis and the semitendinosus. Actually, now there are some techniques to do it with only 1. And the quadriceps tendon with a piece of bone on it is kind of coming back. There's a very famous orthopedic surgeon in Hartford at UConn, Dr. John Fulkerson, who's been using that for quite a while. He's a proponent to that. So I just think we have to understand that there's always a little give and take when we're taking tissue from you. There is some concern with using cadaver tissue or donated tissue, particularly in the young population of a very high failure rate. That also happens to be, though, one of the more popular grafts with some of these professional athletes because they're not losing anything to take it. So I think we need to, when most of the overwhelming majority of us are having these decisions, you know, I think we always need to make sure that, you know, there are other things that go into making decisions with professional athletes, that time to return to play, contracts, et cetera, that we don't make. So I think we need to, you know, at least put that in perspective.
If you're a professional player and you got millions of dollars on the line, then obviously you want to return a little bit faster.
Right, particularly in football where it's not a guaranteed contract, so you don't get paid at all.
And actually, going back to the graft itself, again, one of them is using your own patella tendon, which is right here in the front part of your knee. The quadriceps is actually up above this part of your knee. And your hamstrings, most of us can actually just squeeze the inner part of your leg into here, and you'll feel these tendons in the inner part of your sort of hamstring region on the back side of your thigh. And those are the actual tendons that get rerouted through your knee through new tunnels. Now, I do know that using your patella tendon, some of your quadriceps tendon up in the front part of your knee is associated with a little bit higher rate of what we call anterior knee pain.
Right.
So although surgery went great, they still have some discomfort in the front part of the knee.
Right, and if there's somebody, particularly a recreational athlete, who does any amount of work in a kneeling position, you need to be very careful when you use that graft, because kneeling pain for them or potentially increase the risk of osteoarthritis behind the kneecap could affect their ability to make a living. So I think you just need to be very careful. I think ultimately there's not one graft that's perfect for everybody, but there's a graft that's probably preferable for this patient to that patient.
And then let's say you selected the graft now. There's the 1-tunnel technique and 2-tunnel technique.
Right.
It's usually on the femoral side or your thigh bone side. And, you know, your ACL in of itself is actually consists of two bundles. It's not just one bundle.
Right.
But historically, we only reconstructed one of the bundles.
Right. Yeah, so this is actually evolving, and it continues to evolve probably over the last 25 years. We initially started putting the ACL not necessarily where it started, but where we could get to, based upon techniques, instruments, etc. Over time, we've recognized that although we were recreating part of the knee, we maybe weren't restoring all of the rotational stability. So we have, over the years, kind of gotten, we call it getting lower, but trying to get lower to make a more anatomic anterior cruciate reconstruction so that we can better restore the rotational performance, rotational kinematics of the knee.
So that's the tunnel placement is actually important, not just to provide stability front to back, or what we call anterior posterior, but also rotational stability.
Correct.
So generally, just sticking a ligament within the knee doesn't mean that it's going to be as functional, and that's some of the failures where we see that we have to redo the surgery because you don't get that stability that you want. And that's important between the lower tunnel as opposed to also two tunnels versus one tunnel, reconstructing your native ACL. And that has to be also within the hands of the surgeon. Now, someone who's has expertise in sports like yourself, has done a fellowship and has done essentially sports medicine and arthroscopy and many ACL reconstructions, you have your reasons, just like I have my reasons for doing it the way I do it. Replicating really your normal anatomy, giving that stability back, and staying really ahead of the literature that's out there to show, the reasoning why we choose one or the other.
Correct.
When you have these patients that actually are older, more sedentary type of injury with individuals with some arthritis in their knee, would you do an ACL for those patients?
The answer is kind of depends on the recreation. So if we're saying a sedentary patient, I never use age as a solitary reason to do or to not do. It's more about what that person does. But so certainly a sedentary person who is not participating in pivoting sports, they probably are not going to have functional instability of their knee just kind of walking around. You don't need an ACL to walk around. You need an ACL to stop, cut, and change direction. So they it's not like we don't treat them. They go through a rehabilitation course, and they do just fine, and they do not have functional instability.
And if you have some arthritis, your knee actually gets a little bit stiffer over time, so you don't have as much instability.
Correct.
Well, that's sort of a quick overview of ACL injuries, which we can actually talk about it for the next 2 or 3 hours, the specifics of how it's done and what it entails. But I appreciate your time, Dr. Schachter. Really, you do excellent work, and I definitely see the athletes coming through. And it's really the hands that do it that really makes a difference in how you rehab the patient afterwards and keep an eye on that individual to bring him back to those sporting activities. Stay tuned. We'll be right back and recap today's show about Dupuytren's hand contractures and ACL injuries. Welcome back to Healthcare from the Hill. I'm Dr. Amit Lahav, and today we spoke about 2 orthopedic topics. One was hand contractures, or Dupuytren's disease. We've had Dr. Ted Weisman, orthopedic surgeon specializing in hand and wrist surgery from Milford, Connecticut. And we spoke about these contractures that occur in your hand where your fingers are essentially bent like this, and some of the techniques in order to straighten it back out again. Historically, it's been surgery with definitely some risks involved. But really over the past couple of years or so, this Xiaflex injection or an injection type of procedure can be done in the office setting where you don't have to go to the operating room, which will straighten out your hand. Again, under the direction of a specialist like Dr. Weisman, this technique does have its pros and cons, but in the right hands can give you very good results without going to the operating room. Now, we also touched with Dr. Schachter orthopedic surgeon who specializes in sports medicine and arthroscopy. That's what he does, sports. ACL injuries, anterior cruciate ligament injuries. We only touched the surface on that. We could speak for hours about who occurs, when does it occur, why does it occur, how do you reconstruct it, who gets it, where are the tunnels placed, and the rehab that's associated, because there's been a trend on the change in rehab over the past 10 years, backwards and forward about what is the right rehab after a reconstruction. But ACL injuries, which gives you stability to the knee, if you do lose that stability, reconstruction is really the way it should be done, and really should be done in the hands of a professional, someone who has a specialty in sports medicine, in arthroscopy, who generally does those kind of surgeries. To reconstruct that ligament, you don't just put it anywhere in the knee. There are reasons behind where it should go and what is the right reconstruction for you. Dr. Schachter briefly went over some of the issues with ACL and how do we treat it. But any type of injury, especially knee, shoulder, Dr. Schachter is the professional. Thank you very much for being with us on Healthcare from the Hill. I'm Dr. Amit Lahav, and we'll be back next month with our show. Have a good weekend.